increased intracranial pressure or raised intracranial pressure. First, the normal intracranial pressure is between 10 to 15 millimeter of mercury, which is equivalent to 136 to 204 millimeter of water. It's primarily contributed by arterial pulsations transmitted to the brain directly and through the choroid plexus. Increased intracranial pressure always occurs when there is a disparity between intracranial volume and the intracranial contents. The common causes of increased intracranial pressure, we have localized masses like hematomas, which could be epidural, subdural, or intracerebral. We have the neoplasms, the abscesses, focal edema due to trauma, infection, or tumors. Second, we have obstruction to CSF pathways, which is hydrocephalus. Third, we have obstruction to major venous sinuses. For example, a depressed skull fracture over a major venous sinus, thromboembolic disease from contraceptive pills. Fourth, we have diffuse brain edema or swelling in cases, for example, like encephalitis, meningitis, diffuse head injury, subarachnoid hemorrhage, Ray's syndrome, lead encephalopathy, water intoxication from fluid overload, and finally we have idiopathic. For example, we have the pseudotumor cerebri. Increased intracranial pressure can affect the brain in two ways. First, brain ischemia, when cerebral perfusion pressure is reduced to critical levels, and second, focal masses can cause distortion and herniation of the brain, resulting in compression of critical brain stem structures and the presence of herniation syndromes with occlusion of temporal insula, or the aqueduct further elevates the intracranial pressure by blocking the CSF pathway, which means hydrocephalus. So, what are the symptoms of signs of raised intracranial pressure? Headache, the most common, generalized in nature, nausea and vomiting, and the vomiting is characteristic by being a projectile vomiting, blurring of vision, papilledema, hypertension, bradycardia, ataxia, and cranial nerve paralysis. The treatment is always by eliminating the cause. If it's due to mass effect, blood clot, prompt evacuation of the offending lesion, neoplasm, the hematoma, or divergent procedure of hydrocephalus, means shunting of the hydrocephalus. We have, as we mentioned, ventricular drainage in cases of hydrocephalus, or sometimes you place a catheter inside the ventricle temporarily to reduce the pressure. Second, we can use medications like mannitol, which is an osmotic agent, and it's not metabolized, does not cross the blood-brain barrier. The dose is 0.25 gram per kg at 4-6 hours intervals. It decreases CSF production and increases cerebral blood flow and cerebral oxygen consumption, and it decreases the blood viscosity. Unfortunately, it's only effective for 48 to 72 hours. Beyond 72 hours, it's ineffective because it slowly leaks out of the blood vessels. The other type of medication is hypertonic saline, which has been increasingly used since 2001. Its experimental and clinical studies suggest that it may be as effective as mannitol. Also, we can do hyperventilation, which decreases the intracranial pressure by reducing blood flow and blood volume through vasoconstriction. It's suitable for acute management of increased intracranial pressure and not useful for sustained treatment. We can also use the loop diuretics. The common one is the Lasix or furosemide, which may be used as an adjunct to mannitol because they seem to have synergistic effect. It's thought to reduce CSF production also. Steroids. Dexamethasone used for treating chronic increased intracranial pressure. It's especially those related to vasogenic edema caused by primary or metastatic tumors. It's not effective in vasogenic edema due to head trauma or cerebral infarction. It stabilizes the cell membrane and restores the normal permeability of the endothelial cells. The loading dose is 10 mg intravenously, and the maintenance dose is 4 mg every 6 hours. Barbiturate-induced coma. So the induction of coma with short-acting barbiturate is the last resort in the management of increased intracranial pressure when all other measures fail. The most commonly used drug is thiopental. The loading dose is 3 to 10 milligram per kg over 10 minutes, and the maintenance dose is of 1 to 2 milligram per kg per hour. What about cerebral edema? By definition, it's a state of increased brain volume as a result of an increase in water content. And we have three major types of cerebral edema. We have the vasogenic type, which is the extracellular. We have the cytotoxic, which is the intracellular, and we have the interstitial type, or the hydrostatic. First, regarding the vasogenic edema, or the extracellular, the pathogenesis is increased capillary permeability. And the location, since the blood vessels are inside the white matter, so the location will be mainly in the white matter. And what's the composition of the fluid? It usually is the plasma filtrate containing plasma proteins, and the extracellular fluid, logically it will be increased since it's extracellular, so the fluid in the extracellular compartment will be increased. Examples of pathological lesions: we have the primary or metastatic tumors, abscess, late stage of infarction, and trauma. Now for the second type of the cytotoxic edema, or the intracellular, the pathogenesis will be cellular swelling, including the neuronal and glial and the endothelial cells. The location, since the neurons are present on the gray and white matter, the location will be in the gray and white matter. And the composition of fluid, it includes increased intracellular water and sodium due to failure of membrane transport. The extracellular fluid, logically, it will be decreased since it's intracellular. And examples, we have early stages of infarction and water intoxication. And the last type is the interstitial edema, or the hydrostatic. The pathogenesis includes increased brain water due to impairment of CSF absorption, which means hydrocephalus. So the location, since the hydrocephalus and the CSF is present in the inside the ventricles, the location will be in the periventricular white matter. And the composition of fluid, of course, it will be CSF. And again, the extracellular fluid will be increased. And we have the examples, we have only the obstructive or the communicating type of hydrocephalus. So both types of hydrocephalus will cause interstitial edema, or the hydrostatic edema.